Angiotensin receptor blockers are a class of drugs that influences the renin-angiotensin-aldosterone system. We have been having a review of the renin-angiotensin-aldosterone system, and we have already looked at one of the classes of drugs that influence it. Those are the ACE inhibitors, and today we are going to pay attention to the angiotensin receptor blockers. My name is Judith All Saints Appeal, and I welcome you to my channel, Pharmacology Unpacked for Nurses. I am a registered nurse from Uganda, a nurse educator, as well as an NCLEX tutor. I'm going to look at these drugs following this outline. So we'll start first of all by looking at the examples of the ARBs, and then we look at how they work, their clinical indications, some adverse effects, our nursing considerations, and perhaps also some contraindications to the use of these drugs. Again, understanding this drug really lies a lot in us understanding the physiology of the RAS, and there is a review already on the channel about the RAS system. If you have not watched that, I would encourage you to watch it, and then you come to this and see how it just fits in easily and perfectly. Okay, so what are the examples of the angiotensin receptor blockers? Now, these are the drugs whose names end in the suffix satan, like you see here. Okay, so we have losartan, candesartan, ibesartan, telmisartan, valsartan. If you find a drug whose name ends in satan, you should be able to identify it and correctly put it under the class of angiotensin receptor blockers. Once you refer to them as angiotensin receptor blockers, then you'll easily recall the facts about those drugs, and it'll be very easy for you to say something about them. Let's look at the mechanism of action of the ARBs. Like the name says, the angiotensin receptor blockers, they bind to angiotensin 2 receptor and prevent angiotensin 2 from binding. We can also refer to them as antagonists. An antagonist is that drug that binds a receptor and prevents the agonist of that receptor from binding. So ARBs are going to bind to the angiotensin 2 receptor subtype 1, and then they will block angiotensin 2 from binding. If that happens, we are going to have a reversal of the effects of angiotensin 2. So in the vessels, we are going to end up with a vasodilation. Okay, so you have vasodilation, have a reduction in systemic vascular resistance, and therefore a reduction in blood pressure. And then here, we are also going to have a reduction in ADH. Okay, so we are going to have a reduction in the release of ADH from the pituitary gland, or it's going to inhibit the release of ADH from the pituitary gland. So also we are going to have a vasodilation, and then we are also going to end up with a reduced water reabsorption, which is going to reduce the fluid volume. Then coming to the adrenal gland effect of angiotensin 2 is to release aldosterone. But in this case, again, it is going to inhibit the release of aldosterone. And then what will happen is that we are going to have a reduction in the reabsorption of salt plus water, and we are going to retain potassium. After causing this, you find that because we have dilated the vessels and reduced resistance within them, and therefore reduced the pressure, and then we have also reduced the fluid volume, they are going to reduce the preload and afterload. Remember that preload is the volume of blood that returns to the heart from the body through the vena cava. And then afterload is the pressure against which the left ventricle pumps to push blood to the aorta and then to the rest of the body. So there's going to be a reduction in afterload and preload. Also, when we have a reduction in volume, we're still going to have a reduction in preload, and we are still going to have a reduction in preload. If we have a reduction in fluid volume, the preload will as well be lowered. So at the end of the day, the vessels are not put under a lot of pressure, the heart itself is not put under a lot of demand, and these drugs are therefore going to reduce cardiovascular remodeling. Let's look at the clinical uses for these drugs. So the first indication is going to be hypertension. Because these drugs reduce resistance within vessels and reduce the blood volume, of course, they're going to reduce blood pressure. And then they also reduce the cardiac remodeling. Therefore, it prolongs the life of the heart. They are protective against diabetic nephropathy or even in clients with non-diabetic nephropathy because they're going to reduce the glomerular filtration pressure and rates. And then they are also of benefits to clients with coronary artery disease and myocardial infarction. Let's now look at the adverse effects of these medications. Because they reduce pressure, they are going to cause hypotension. In fact, some books say that the ARBs produce a greater degree of hypotension compared to the ACE inhibitors, but they all cause hypotension. And the hypotension is again worse in clients who are also taking other antihypertensives. Then, because the drugs are going to block the effect of angiotensin 2 on the adrenal gland, we will have less aldosterone, so we lose sodium and we retain potassium. So we end up with a hyperkalemia. These drugs also cause neutropenia and a granulocytosis, and the patient may manifest with a sore throat or a fever. And then, just like the ACE inhibitors, they are teratogenic. So we do not give them in pregnancy. We also don't want to give these drugs in clients with hyperkalemia. The nursing considerations, of course, is going to be informed by what these drugs produce. So we want to monitor the vital signs, especially the blood pressure and then the pulse rate. We also monitor serum potassium because hyperkalemia is toxic to the heart. You may end up with an arrhythmia. We need to monitor the renal function, BUN, and then creatinine. At the same time, we also want to exercise caution in case the client is on any other blood pressure lowering drug because then we may have additive hypotension. And what are some parts of the client's teaching? So in client's teaching, of course, because these drugs because these drugs are going to cause hypotension and potentially orthostatic hypotension, we teach them to gradually change position so that we give time for the hemodynamics to stabilize. Otherwise, a sudden change in a position from maybe sitting or lying to standing could drop the pressures very low, and that can cause the patient to fall and then they sustain injuries. Also, we teach them not to abruptly stop taking the medication, otherwise they may end up with a rebound hypertension. These drugs are not given in pregnancy because of the teratogenic effect. So we are going to teach the female patients to report pregnancy because then the drug would need to be held. Also avoid potassium supplements, avoid potassium sparing diuretics, okay, because they are as well going to increase the levels of potassium. Then teach the patient to take their blood pressure. A key thing that you need to know about the angiotensin receptor blockers is that they do not have the bradykinin blocking activity that the ACE inhibitors have. For that reason, they do not cause cough, and then they are also not really associated with the angioedema and hypersensitivity effects that are common with the class of the ACE inhibitors. And for that reason, they become excellent alternatives in case the client develops an intractable cough or if they develop angioedema. So those will be alternatives. Otherwise, in terms of clinical indications, these drugs really do the same thing. At the end of the day, they're all going to interfere with the activity of angiotensin 2. And that brings us to the end of the review of the angiotensin receptor blockers. I hope that it has been helpful, and I'd like to request that you subscribe to my channel, like this video, and share with your friends so that it might get to a wider audience. I thank you.